So I was talking about body mass index and getting weight down. Another thing about knee replacement, knees that I have to talk about as a joint themselves, the amount of torque that is estimated to go through a knee is anywhere from 5 to 10 times your body weight. So I tell patients that, that means if you lose 10 pounds, that's 50 to 100% less torque going through your knee. It's huge. And so that's one of the ways I encourage people to lose weight. Non-medical treatments for arthritis, obviously weight loss. The more weight you can get off, the better. Your joints will feel better. They will be happy not carrying that extra weight. Think about bridges and how much weight a bridge is allotted to carry and how much longer the bridge will last when it doesn't have to carry a lot of heavy weight. Exercise, yoga, Pilates, and water aerobics. These are great exercises. Walking, obviously. But for people who really hurt, getting in the water helps. But yoga helps with stretching, which is really important for arthritis people. Pilates helps with core strengthening, which is good for backs. Most people, have this big gut that's hanging off their back, and it's pulling a lot of traction and causing a lot of muscular back pain. So core strengthening is incredibly important. Medical treatments, Tylenol is always our first choice, but unfortunately it doesn't work very well. Most people don't get much more relief from it, and recently we decreased the amount to only 3 grams a day maximum, even less than that if you drink or have any liver disease. So Tylenol is not a great answer. Anti-inflammatories, Advil, ibuprofen, these are great drugs if you use them for the short term, but unfortunately our older folks with arthritis want to use them for the long term, and then there's major issues. And those major issues, number one, is a stomach ulcer that results in a GI bleed, and that is deadly. It can be. It raises blood pressure. It causes kidney damage. Anti-inflammatories are not a great answer for long term, and I don't like to prescribe them for long term. I really encourage people to come up with something else. Prednisone and steroid injections, these are great options. Typically they only give 1 to 3 months of relief, but for someone who is too old to consider surgery, in their 90s, later 90s especially, or if it's like a shoulder, which is not a weight-bearing joint, they come in every 3 months and get a cortisone shot, and it makes all the difference. And it makes them reduces their pain, they can function, and they're really a great option. Unfortunately, prednisone just decreases inflammation. It does not fix the underlying problem. The arthritis is still there. Hyaluronic acid injections. These are only approved for knee arthritis. They're not approved for any other joint. I've used them in ankles. I know people have used them in shoulders, and they do work in other joints, but they don't have the studies to present to the FDA to get approved for those indications. These work, I think, but they're very expensive as compared to cortisone shots. The hyaluronic acid injections run usually $500 to $1,000 for the series. It's usually 3 to 5 shots, 1 a week, for 3 to 5 weeks. But the American Academy of Orthopedic Surgery came out with a big position paper on knee arthritis a couple of years ago that basically said that most of the studies on these hyaluronic acid injections were done by the companies that make them, therefore they're suspect, and they don't endorse them. And since that paper has come out, major insurers like Blue Cross and Blue Shield no longer pay for these injections. So now patients are having to pay out of pocket. I definitely see some improvement. My mom has had them. She's reported improvement, but that's anecdotal. It's certainly not a major study done under double-blind, placebo-controlled sort of research that we like to do. Glucosamine chondroitin, it probably doesn't help much. There's people out there that believe in it. It's pretty safe. It doesn't interact with any other drugs, but it probably just costs the patient money. It really doesn't do much for arthritis. Joint replacement, surgical treatment, joint replacements work great. They have over a 90% success rate for hip and knee replacement. And nothing in the horizon looks like it's going to take the place of these surgeries. I just read recently about 3D printers creating a scaffold for a meniscus so that you could replace a meniscus. That's nowhere near fruition. We're not there yet. For years we've tried to do chondrocyte cartilage sort of transfers. They don't work very well. They're not FDA approved, and these are usually for young kids who chink a piece of cartilage off inside their knee. And the parents have to pay anywhere from $20,000 to $30,000 out of pocket for this treatment that really has no evidence of efficacy. So that's worrisome. We don't have great answers for young people who chink cartilage. And so I predict that as I retire, we'll still be doing joint replacement. This is going to happen, they say, by 2030, and that's about when I plan on retiring. So joint replacements do work very well. Back in the early 90s, when Hillary Clinton was investigating basically how to help with health insurance and this sort of thing, one of the things she looked at was bang for your buck surgery. Hip replacement was considered number one. For the amount of money we put into that surgery compared to how much the individual then contributes back to society, hip replacement's number one, knee replacement's number three. I don't know what number two is, but I would guess it's probably cataracts, because you take somebody who's almost blind and allow them to see again. So you're taking someone who's become almost non-functional and making them a functional contributing member of society again. And so knee and hip replacement are greatly effective. They work well. They do have some major complications that can occur, but those risks are quite low. And you take someone who has become quite debilitated and make them functional. And they're really the only thing we have over the next 30 to 50 years that I think are going to be available for arthritis. Shoulder replacements work well, but most people don't choose them because they don't walk on their arms. Elbows, not so much. There are some replacements for fingers, these joints inside the hand, kind of where that area is right there. There are some metacarpal joint replacements for people with rheumatoid arthritis. Those aren't done very much. It's mostly hips and knees. Ankles are still somewhat questionable. We're still trying to get those figured out well. Hip replacement became available in the 1960s, became quite accepted fairly quickly. Dr. Charnley, Charnley in Britain, was the major founder of hip replacement. And in the 70s, knee replacement became much more prevalent. Knees were a little bit trickier. Hips are a ball and socket joint. That was figured out fairly quickly. They don't have a lot of motion. Knees actually do more than just bend and flex. They actually twist a little bit. There's a little bit of a torsion quite at the end of knee flexion, knee extension actually. And so that took a little bit more work. The rotating knees don't work as well. They actually wear out faster, and the gender-specific knees are of no consequence. That's just a marketing ploy. So now we're going to talk about osteoporosis. This is a major, major concern, and the reason why is most of us don't build our bone mass when we're young, when we need to build it. Peak bone mass is achieved around 30 years of age. Some of it's earlier, up to 40 for certain bones. But the truth is, I like to think about osteoporosis as putting money in your IRA, that you deposit it until you're about 30, and then after then, you're making withdrawals, and you're starting to pull away from your bones. 10% of our skeleton is remodeled every year between the osteoclasts and the osteoblasts. Adults, after skeletal maturity, lose 1% of bone each year, both men and women. And women have an accelerated bone loss for 5 years after menopause. And that's why women are more likely to develop osteoporosis. The most common fracture sites are the spine, vertebral fractures, compression fractures, the wrist, and the hip. After age 50, women have a 40% lifetime chance of an osteoporotic fracture, while men only have a 15% chance. But we can't forget men. Men who have other risk factors, particularly chronic prednisone use or steroid use for things like emphysema or any kind of rheumatologic condition, they'll develop osteoporosis too. So this is not something we can ignore. Non-medical treatments, obviously calcium and vitamin D. Some people cannot take extra calcium. If you have a history of kidney stones that are made from calcium, you're not allowed to take extra calcium. But by and large, most people calcium. Vitamin D, most older people just don't get sunlight exposure. So either they have to take the vitamin D, and we tell folks to wear their sunscreen to not get skin cancer, but actually a little time out in the sun helps do that photosynthesis that we need for vitamin D conversion. Weight-bearing exercise. For arthritis, we talk about, get in the water. That feels so much better for your joints. It's not good for your bones. It takes the weight and pressure off your bones and does not allow them to get stronger. Weight-bearing exercise, whether it's walking or weightlifting, is what you need to help build strong bones. Fall prevention strategies. There's a whole bunch of these things out there, and one of them is, loose rugs, not having cords across the floor, and just being smart. One thing I run into on a regular basis with my older folks is they don't want to use canes or walkers because they don't want to look old. And so they'd rather risk a hip fracture than be safe and be steady. We all have balance issues the older we get. We need to use those balance assistant devices if we need to. And actually, Tai Chi has been shown for both Parkinson's and just balance issues to help improve balance. So any kind of physical therapy Tai Chi that helps improve balance is good. And also just a home survey of the rugs, the cords, anything, small pets that might contribute to people falling. Stop smoking. The number one thing I think about, when I think about people with osteoporosis, I think small, petite, white or Asian women with who smoke. They start off with small bones to start with, they're very small to start with, and then they smoke, and that draws even more calcium out of their bones. And reducing alcohol intake. I still think that the time to prevent osteoporosis is when you're young. That if you see a young, skinny female who only drinks soda and no milk or yogurt or cheese, this is a girl who's going to get osteoporosis. Soda, the phosphorus in soda actually competitively binds with calcium on the receptor sites. So soda pop, whether it's Coke or whatever, is actually a problem. And so we need to fix osteoporosis at a young age. Once we get to 70, the horse is already out of the barn. I've done so many surgeries, I can't tell you. By 70, the bone is soft. By 80, the bone is butter. It's just so soft. I can actually push it with my finger and break it. The horse is already out of the barn at 80. I see all these things on our gerontology things that talk about, how we can build bone. Not at 80 or 90. It doesn't happen. The bone is too soft by then. So you start building your bone as a young person. You put money in the bank until you're 30, and from then on you're making withdrawals. Medical treatments. These are incredibly individualized. We have not yet come up with the perfect bone building drug yet. The bisphosphonates they build bone, but the question is, do they build quality bone or do they build brittle bone? They have some concerns such as osteoporosis of the jaw and subtrochanteric fractures. So the question is that maybe they don't, while they increase bone density, do they actually make good bone? And so that's still being debated. There's a great drug called Forteo, which is parathyroid hormone supplement. It's really indicated for people who have very severe osteoporosis. It's incredibly expensive, and I think as a society we cannot afford Forteo for everyone with osteoporosis, unfortunately. So deciding the medical drug is very individualized, and we don't have a great drug answer yet. With the bisphosphonates, we first thought you went on them forever. Now we're thinking you go on them for 3 to 5 years, then you take a drug holiday, and we watch this with DEXA scans. And when you start falling down again, you start taking it again. With the bisphosphonates, you have to be somewhat careful about how you take them. You have to stay upright for 30 minutes. You can't lie down or eat or drink